years, and then I went outpatient oncology. And when I worked inpatient, I felt like it was only a matter of time before everybody got cancer and that nobody survived cancer. Working outpatient, I did see a lot more patients getting through their treatments, going into remission, having positive outcomes. So being on the inpatient side, it was sad. It was a lot of end of life care, symptoms and bad reactions to chemo on the inpatient side, where they were in the hospital for weeks, sometimes months, getting over just one dose of chemo sometimes. But it was very draining and very eye-opening. Not going to read all over these objectives, but they're up there for you. I know we've reiterated over and over, know your labs, know your labs, know your labs. These are just a few that for your CBCs, kind of know your white blood cells, your platelets, your hemoglobins, those PTs, PTT, INRs, all those. Don't get caught up on the details of, well, this book said it was white blood cells were 5,000 to 12,000. You know, don't get caught up on the details. If we're going to have an abnormal lab value, it's going to be abnormal. It's not going to be like your white blood cells are 4,500 and you got to know now that that's low. So you would be looking at like your white blood cells or 2,000 or something like that. Your platelets, 80,000, something like that. So it's not going to be barely off of the normal, because we know that all these ranges are different in any book that you look at, right? Any questions on these labs? So what is your white blood cell going to tell you?
Presence of infection.
Infection, if it's increased. What about if it's decreased?
You have more risk to catch an infection.
Means you don't have those white blood cells readily, you know, able to fight off that infection. So you're at a higher risk for infection, right? Yeah. What's your platelets going to tell you?
You're clotting.
Bleeding and a clotting factor.
Okay, so it's going to, platelets, of course, clot to keep you from bleeding out. So if it's low, what are we at risk for?
Bleeding.
What about if it's high?
Clotting or clots.
Clots, blood clots, yeah. What's your hemoglobin hematocrit going to tell you?
Well, your
hemoglobin is your red blood cell count.
Red blood cells, right?
Those are your oxygen carrying cells, right? What if it's high? Got you on that one, didn't I? What if it's low?
Well, if it's low, then you're probably not going to be very well oxygenated. Tissue won't probably perfuse well.
Blood loss or poor iron in your diet.
Okay, so anemia, right, Brittany? It could indicate that you have blood loss of some kind. It could mean that you're bleeding somewhere. If it's really high, you're going to have more, you know, like a thicker blood, right? So which labs are we going to look at if we're thinking we're going to do a blood transfusion? Looking at our CBC with our white blood cells, hemoglobin, hematocrit, platelets, and RBCs, which one's going to be an indicator that we may need to transfuse blood?
Red blood cell.
Red blood count.
Wouldn't it be hematocrit?
It's going to be your hemoglobin and hematocrit. Yeah. Those are going to be your first indicators that you're going to need possibly a blood transfusion. Your red blood cells are kind of going to go down with it, but we really focus on those oxygen carrying blood cells because that's going to be what's getting the oxygen throughout your body, right?
And what did you say? I remember someone, I want to say I remember the number at which they transfuse is what? Like the
Usually less than 7.
Okay, yeah.
So typically when they write orders for blood transfusion, it's a hemoglobin less than 7, or if it's dropped more than 2 points within a 24-hour period. So if you come in and it's 13 and then the next morning you're at 9, that's a big difference, right?
Yes, ma'am.
What can cause that to happen?
The drop, their oxygenation level, their respiration, they're not getting enough oxygen.
That's not going to cause your hemoglobin to alter. So think about dehydration. So if you're dehydrated, everything's more concentrated, right? So if you have a patient come in and they're dehydrated and their hemoglobin is 13 today, you may think, oh, their hemoglobin's normal, not knowing that they're dehydrated. And then once you start hydrating them, what do you think could happen?
Hemoglobin will go down.
It'll drop.
Then it's going to drop, right? Because it's going to give you a more accurate reading because now you're not as concentrated because you're dry, right? Does that make sense?
No, can you say it again? Can you say it again for me? I'm sorry.
So when you're dehydrated, everything's going to be, all your cells are going to be a little bit more concentrated. So it's going to give you that false high. Once you start hydrating them and getting those fluids in them, you're going to get a more accurate reading because you're going to have a more stable environment. They're not going to be as dry and as concentrated.
Great, thanks.
Which lab do we look at that will give us an idea that they're at risk for bleeding?
Platelet.
It's going to be your platelets. We're going to look at our platelets to determine if we're at a risk for bleeding, right? Would we look at hemoglobin and say, just because it's low, do we have a risk for bleeding?
Not necessarily.
So your hemoglobin may indicate that you have a bleed or that you have had blood loss, but it does not increase your risk for bleeding. Those low platelets is what's going to increase that risk for bleeding. Does that make sense? So if I have a GI bleed and I come in, my hematocrit's 7, but my platelets are 200,000, just because my hemoglobin is low doesn't mean I'm at risk for bleeding. It's saying that I am bleeding, but I'm not at risk for bleeding because my platelets are good, right? All right, so we're going to talk about mostly cancer in general. I did put some highlights for the specific cancers, but basically, you know, think about cancer in general. And then if you have to go into the specifics, look at breast cancer, lung cancer, all those different cancers and see what sets them apart from each other. We're going to talk about hepatitis, viral versus non-viral, and briefly go over herpes zoster. All right, like I said, I'm not gonna read these things out to you, but protection is pretty much your primary defense and secondary defense to protect your body, right? So what's some of our primary defenses?
Our skin is the first defense usually.
Skin is our big one. So if we have any breakdown in our skin, that's going to let things in, right? And then we may no longer be protected. What's our secondary defenses?
Our immune system.
That's our immune system. So when our primary defenses are lacking, then our secondary defenses come in and help battle it out, basically, to get whatever's happening in your body out of there, right? So what are some things that can happen with your body when these defenses kick in?
Fever.
Fever,
Fevers. What's it trying to do when you have a fever?
fight off the infection.
Right off.
It's trying to burn it out, right? Smoke it out. What else?
Inflammation.
Inflammation. So with that primary defense, when you get a scratch or a wound, it's gonna be inflamed, it's gonna be red, and that's everything rushing to that site to fix it up real quick before it gets inside, right? Anything else?
Would you count coughing and sneezing if something gets up?
Absolutely. So sneezing, what's sneezing doing, and coughing?
On the clear airway.
You're clearing those airways. What about vomiting and diarrhea?
Right in GI tract.
It's not always a good thing to stop up that diarrhea, is it?
No.
No, you want that out.
You want that out. Think about, I don't know if any of y'all have had this experience in the hospital, but typically when your patient's having a diarrhea, what do they do before they give them something to stop them up? Do y'all know? What do they check for?
Do they culture it or
Hospital
something?
acquired infections.
What's that big one that's real harsh on these
Like
patients?
C. diff?
C. diff. A lot of times they're going to check for C. diff before they decide to stop it up, because if it is C. diff, we don't want to stop it up in there. We want the body to get it all out, right?
Tell that from smell and consistency. Ugh.
Yeah. If you've had a patient with C. diff, you'll never forget.
Can you
All
just
right.
have to smell, or is it something you just have to smell for yourself?
You just have
It's
to smell for yourself.
You just have to smell it. I mean, there's no describing it.
You said the skin was the first, immune was the second, and what was the third? Or was there a third?
No, so skin, all the little, your hairs, your eyelashes, all that on the outside is going to be your primary, and everything on the inside is going to be your secondary.
Okay, thanks.
Tertiary would be like your medications and stuff that you would take. All right, so just some terms to know. Metastasis is a big one. What does that mean?
It's
When-
spread everywhere.
It means it has spread, cancer has spread to somewhere else in the body. And what kind of things, what kind of routes do they take to be able to spread to other parts of the body? How does it
through the
spread?
blood?
Lymph nodes.
Lymph nodes, through the blood system, the lymph system. If it's next to each other, it can kind of spread to the organ next to it. We're going to talk about neutropenia, but what is neutropenia?
Low
They don't have no
neutrophil
line of
count?
defense, right?
What was that, Tanae?
They don't have any line of defense. They white blood cells is low, so they at risk for infections.
Yeah, decreased white blood cell, specifically those neutrophils, which are your baby white cells. So if your white blood cells is low, like we talked about, you're going to have trouble fighting off infection. So when it's less than 1,500, they're going to be considered neutropenic. When your white blood cells is less than 1,500, they're neutropenic. Nadir is just the point where everything's at its lowest. So typically you get chemo or radiation, and it kills off all the good cells and the bad cells. And that nadir is going to be that day where everything is at its lowest point before it starts coming back up. Does that make sense? All right, what is thrombocytopenia?
Low
Yeah,
platelet count.
low platelet count, yeah.
All right. So low platelets. And what does that put us at risk for?
Bleeding.
Bleeding out.
And what, has anybody seen extravasation before?
That's when the medicine or whatever has leaked out into the skin, out of the vein or artery.
Yep.
We've seen it in some PowerPoints from you guys, like with the guy's arm, and then it was all like
Yeah.
toward his wrist.
Yeah, so we really focus on our IV sites, especially when we're given chemotherapy medications. Many times they will put it in a larger, one of your larger, more heavier IV veins. So you'll see they may have a port, they may have a central line. So those are going into those bigger, heavier duty veins, whereas your peripheral veins with your IVs, those are not as strong and they can be damaged a lot easier than those like your the ones up closer to your heart, right? So if they are getting medications through an IV, you have to be very careful that you're looking at the IV site. It's not red, inflamed. It's not leaking out into the sub-Q tissue because it can cause a lot of damage. It can cause burning. It can cause excoriations. It can even cause a patient to have a limb amputated. We talk about it here with chemotherapy drugs, but one of the more popular drugs that is very hard on the sub-Q tissues is your Phenergan, your promethazine. It's only to be given IV and IM. So if you get it into that sub-Q tissue, then you're going to have a lot of damage done to that patient. I've had patients actually lose limbs from the Phenergan getting into the sub-Q tissue.
And is that from the medicine being so abrasive that it
Correct.
breaks down the vein, or so it's not from us poking from one side of the vein, putting the needle too far and poking out the other side? And so
it can leak out of, if that vein doesn't fix itself. A lot of times you'll see chemo infusion nurses that if they go through the vein, they may actually go somewhere else so that when they start the chemotherapy medication, it doesn't leak outside of that vein where you went through it.
Okay.
You said it would be IV or IM?
Correct. All right, so we're going to get into the cancer. Pay attention to what your normal cells look like versus your cancer cells. What do y'all notice?
Cancer cells, they look, I mean, they're larger. They got kind of more borders are more, I guess, irregular, you'd say.
There's usually more, larger, bigger nucleus. Their shapes are kind of just out there somewhere, and they really don't have a lot of features. So when you're looking at your cells under your microscope, if y'all happen to do that, then you're going to notice a big difference between the normal cells and the cancer cells. I'll have you review your patho on your own. I won't test you on this, but these are things, you know, your pathos, what you got to know in the back of your head when you're caring for these patients to really know what's going on in the body when things are happening, or when you're given medications, or if they have something else going on. You kind of have to relate everything together. So what do y'all know off the top of your head are risk factors for cancer?
Smoking.
Okay.
Smoking.
Alcohol, sun exposure. Too much.
Environmental factors like what you would, asbestos or things that you breathe in.
Pretty much everything causes cancer, right?
Yes.
The big ones: smoking, drinking, your diet, no exercise, everything that we tell people to do to lead a healthy life, doing the opposite can cause cancer, right? Sometimes it's genetics that we have no say-so in, right? We can't change our genetics. And sometimes things just happen over age, so we can't really change that either. But we can protect ourselves from the sun. We can not smoke. We can drink moderately, right? those red wines, right? Making sure that you're eating a good, healthy diet. What else? Keeping ourselves protected from viruses, getting our vaccines, all of those things. Whenever somebody figures out how to reverse age, then we might cut back on that risk factor, right? What do you think is going to bring a patient in to be diagnosed for cancer? What are some things that get patients into the hospital?
Spots on their body, abnormal spots.
Okay, those weird looking mole things, right? We may worry about those.
Under the skin and weight loss.
That unexplained weight loss. Do you think that's going to be something that's really going to be noticeable right away?
No.
No.
So that one's going to be a gradual, and sometimes people don't even realize until all of a sudden their clothes are just falling off of them, right?
Mm-hmm.
Somebody said pain.
That's probably the biggest one.
That's going to get me in somewhere, right? I mean, I have a high tolerance for pain, but when it lasts and lasts and doesn't go away, then that's going to get me in there to figure out what's going on, right? Bleeding. Usually if we have some abnormal bleeding, that's going to scare you and get you in, right? Especially blood noticed in the stool, right?
Headaches, vision problems.
Some type of infection. Fatigue, again, that's going to be one of those that you're going to notice gradual. I've had so many people, and you guys probably too, being in nursing school. Are you tired all the time?
Yes.
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 So a lot of these people chalk them up. You know, I'm so drained, I'm so tired, but I've had this going on this week. I've had 3 tests to study for. I've had this headache, but it's because pollen's out there. I've been sneezing a lot. You know, I'm going to take my allergy medicine. And you see how people kind of put things to the back burner, how you can chalk things up to other things. And a lot of these people talk themselves out of it. And then by the time they do go in, because it's been lasting months and months and months, then a lot of times they're being diagnosed late stages. Let's see. How about diagnosing cancer? What's the best surefire way to diagnose cancer?
A biopsy.
That biopsy. We're going to do blood tests. We're going to do scans, x-rays, all of that. But those are kind of leading us down the path. It's kind of ruling out things to get us on the right path so we know exactly where we're going to biopsy, right? Your x-rays, your CT scans may show something in the lungs. Then we're going to go in there and we're going to biopsy whatever that is in the lung. And that's going to tell us, that's going to help us with staging. It's going to tell us where it originated, all kind of things, right?
Mm-hmm.
It's going to kind of guide our treatment. What's the best treatment for them? Do we need to do surgery? Do we need to add some radiation? Do we need to do chemotherapy? All of that. So that biopsy is going to be that gold standard for diagnosing our cancer. Again, medications, they have hormone therapy, immunotherapy, we have chemotherapy, we have radiation, and then we can go through different surgeries, cut things out, make things smaller so that they can be treated with chemo or radiation to shrink them even more, that kind of thing. What is, with skin cancer, do y'all know what the main treatment for skin cancer is, for melanoma?
Isn't it just cutting it out?
Cutting it out. So that's your biopsy and treatment all in one, right? And many times while they're in surgery cutting that out, they're going to look at what they call the margins, which is the edges of what they cut out, to make sure that they got all of the cancer cells out of there so it doesn't stay and and spread to other places. But we're going to focus on chemo, radiation, and we're going to talk a little bit about surgeries. So we're going to talk about side effects of chemo and radiation and how we're going to deal with those, right? Because really, that's what we're doing at the bedside is we're supporting our patient, we're preventing infections, preventing complications, and we're getting them through the side effects of their treatments. So these are just some complications. What do y'all think? Those that have seen people go through cancer treatments, what were their biggest complaints?
The loss of their hair.
Hair loss, loss of appetite.
Hair loss, loss of appetite, nausea, vomiting. What was that today?
I was nausea and vomiting. That's what I said.
Some things that go on the inside, oh, excuse me, that you may not necessarily see on the outside is that those cells, the white blood cells, your hemoglobin, your platelets, all of those being attacked by the treatment, whether it be chemo or radiation. So it's going to kill those cells because it can't pick out the healthy cells from the bad cells, right?
Right.
So when we do our CBCs, our lab work after treatment, we're looking at that to see how at risk these patients are for these things. So if they have thrombocytopenia, what are some things that we're going to do to protect our patient until they're not thrombocytopenic anymore? So if they have thrombocytopenia, what does it put them at risk for?
Bleeding.
You do platelet.
Risk for falls or injury.
So it's going to put them at risk for bleeding.
Right.
So we don't want them to fall, right? Because what can happen if they fall?
Then bleed everywhere.
You cut themselves.
They can cut themselves. They can have outward bleeding. They can have damage on the inside and have internal bleeding, right? Especially if they hit this head. We don't want that bleed in their head and get that brain bleed, right? What are some other interventions we're going to do to help these patients with no platelets?
Infusions.
We can transfuse platelets. Usually with platelets, we're transfusing at 20,000 or less. They let it get down that far because they really want that body to kick in and start making its, making its own supply of everything. What was that?
I said nutrition.
Nutrition is a big thing. So chemo makes them nauseated, makes them vomit. They don't have an appetite. Their taste may change, so then things are just not satisfying anymore. So what are some things that we can do to help with their malnutrition?
Give them small.
Give them those small frequent meals, right?
Yeah, and supplements.
Give them those supplements. If they're not eating anything else, the best thing to do is give them a meal in a can, right?
Yes.
They get everything they need in only a little bit of amount, right? And sometimes, making them cold or making them kind of like a little bit frozen. It feels good going down their throat, that kind of thing. What about infection? How can we prevent infection with them?
Keep them away from people, people that has been sick recently.
Make sure
fresh fruits, nothing like
Hygiene's
newspaper and stuff.
Or kept up. Their hygiene's kept up.
Yep. So again, we're back down to the basics. Hand washing, stay away from people who are sick, right?
Yes.
Keeping our environments clean. We'll talk about what Tanae said, the fresh fruits and veggies and all that in just a minute. But just back down to the basics. I mean, basic hand washing is going to cut down on a lot of that, right? keeping our skin nice, moist, clean, making sure that, you know, if we're neutropenic, maybe now's not the good time to go out to Walmart or to church where there's a lot of large groups of people that may have different things going on, right? I think of kids as walking bacteria. So, you know, maybe now's not time to go visiting, you know, a group of kids, right? So our basic things that you don't really think about all the time as being nursing interventions is what we're going to do to prevent infection. And that's what we're doing all the time, right? Do y'all know what mucositis is?
Inflammation of the mucosa. Oh.
Yep. So
Does
they'll
that
get
happen? Oh, sorry.
they'll get mucositis in their mouth, which is inflammation in the mouth. They can also get stomatitis. You know what stomatitis is?
Ulceration in your stomach. Is that right?
It's actually your tongue,
Okay.
inflammation of the tongue.
Oh, okay.
And they also get thrush.
Yep, I was going to say that too. So here is a nasty picture of mucositis, stomatitis. Always, we always forget the mouth, but always look in your patient's mouth, especially if they're on antibiotics, because they can get thrush real easy. Do y'all know what thrush looks like?
It's white and pasty looking on the tongue.
White and patchy on the tongue. So always just, you know, open your mouth, stick your tongue out, and see what that mouth is looking like, because think about whatever's in your mouth. What are you doing with it?
Put it in your body.
You're swallowing all of that, right? So any bacteria, any kind of viruses that are in there, you're constantly swallowing all that down. With our cancer patients, we got to be real careful. A mouth is sometimes usually the first sign of an infection. If they brush their teeth too hard, the flossing and they hurt their gums, you know, that's just opening up for bacteria to collect and get infected, right? Mouthwashes, we got to be careful with mouthwashes because they can be real harsh. How many of y'all use mouthwash and it burns your mouth?
Yes.
We don't want that for our patients. They do make alcohol-free mouthwash that we would recommend. We recommend soft bristle toothbrush. And we don't recommend to stop flossing, but you may want to use other options. They have the, you know, the water picks, things like that. But if you don't normally floss, now's not the time to start, right? Because you're going to have those bleeding gums. You're going to be ready for all that bacteria to start building up. We talked a little bit about anemia. Which lab value are we looking at for that?
Hemoglobin?
Your hemoglobin hematocrit. What can we do to help with anemia?
Would that be a blood transfusion, or is that?
If it's bad enough, we can transfuse blood.
Or you can give
Maybe we
iron
start with diet.
supplement.
Iron supplements. Who said the last thing?
I was just saying maybe we start with diet, you know, increasing the red meat.
Yep, those red meats. What do you recommend those who are anemic? That red meat, right? Eat a steak. Is that what they say? All right, and then alopecia is a big one. Everybody pretty much knows if they're going to get chemotherapy, they're probably going to lose their hair, right? Do y'all know why that is?
It was all, like it goes after all dead cells.
It hits, chemotherapy hits those rapidly dividing cells a lot faster. So it's going to hit those. That's your hair follicles, that's your skin cells. Again, that's why we get a lot of mucositis and stomatitis, is because that's part of those cells that are rapidly dividing, and that chemotherapy attacks them pretty quickly. One thing I want to point out is if your mouth looks like this, think about your whole GI tract. What do you think your throat looks like?
About the same, probably.
About the same. It's going to hurt when you're swallowing, right? It can go down into your esophagus. What you're going to notice, what kind of symptoms are they going to have? If you have irritation in your esophagus, what do you think?
Malnutrition.
Difficulty swallowing.
It might feel like heartburn. It's going to hurt. Think about it in your stomach. What if your stomach lining looked like that?
Yeah, food's probably going to irritate it.
Going to be irritated, nausea, probably vomiting. Think about your colon. You might have some cramping, and then what are you going to have out the back end? Probably some diarrhea, right? So that's why a lot of these things are related. Malnutrition, mucositis, infections, anemia, losing your hair, all of these things are all because it's attacking those rapidly dividing cells, right? Well, that was a lot. All right, we talked about malnutrition. Always remember we have lovely meds to give them with everything. Pretty much any symptom that you can have, we can throw a pill at it, right? So nausea, we have nausea medications. We do have medications that you can give to help stimulate their appetites. Back when she was talking about your bariatric surgeries and not drinking with your meals, think about that here too, because if you're drinking a lot of liquids, what's going to happen? It's going to make you feel fuller, and so you're not going to eat as much.
Okay.
So you're going to get a lot of these empty type calories. Avoiding those hot foods. We don't want to burn our mouths, right, and cause sores or anything. So eating those room temperature foods, focusing on those calories. If all they want to eat is a milkshake, by golly, let them have a milkshake, right? Anything we can get in them. And we talked about those supplements. We talked about the mucositis. Did I say soft bristle toothbrush? I can't remember if I said that.
You did.
Think about if your mouth looks like that. Think about when you've had a sore in your mouth. What foods do you want to stay away from?
Acidic.
Those acidic foods. I just think about ketchup and salt, and your mama will tell you gargle with salt water. That hurts, all right? So just think about when you've had those sores in your mouth, what all you wanted to try to avoid. You were real easy brushing your teeth, weren't you?
Yeah.
We want to make sure they keep a clean mouth, so we're going to tell them probably, use that soft bristle toothbrush after every meal, so we don't have food particles and everything sitting between our teeth and building up that bacteria to where we're going to get infections. All right, so anemia and thrombocytopenia. Here's one of the medications to increase the RBCs for anemia, the epoetin alpha. I don't know if any of y'all have given that this semester in clinical. Does that ring a bell for anybody? No. We're going to give ferrous sulfate. What is that? I know we gave a lot of that on our floor.
That's iron.
That's your iron. Watching for any bleeding, usually out of our nose, in our mouth, in our urine, in our stool, looking for any excessive blood, right? Why are we avoiding IVs and injections?
So you can avoid extra bleeding.
Correct. Yeah. So sticking them is going to make them bleed, right? If you put in an IV, you may have bleeding around the IV site. If you're giving injections, you may have to prolong the pressure on it to keep him from bleeding as much. So we're trying to do everything we can to prevent them from bleeding out, right? So what kind of teaching are we going to do for these patients?
Soft
Depends.
toothbrush. Be careful with your oral and check your mouth a lot to see if there are any adhesions or anything. And then just being careful day to day, not bumping into anything, not doing anything super active that could potentially make you bleed.
Right. Tell them take Tylenol for pain, right?
No.
No, we're going to cut back on those NSAIDs, right? And staying away from razor blades, like with shaving legs, faces, underarms, because you don't want those blades are sometimes sharp and you can get cut. So sticking with those electric razors if they need to shave. All right, so any questions on chemotherapy, any of these side effects from or complications from chemo or treatments? All right, so what is radiation?
Well, I mean, you're destroying, I guess, cancerous malignant cells with it, you know.
Yep, so that's going to be that targeted area. They're going to be able to target a specific area as opposed to, you know, on the inside where you're targeting all those cells. They will actually mark off different spots. You might see markings on these patients. A little bit of education. Don't go washing those markings off because they have those on there so that they know exactly where to aim that radiation beam. Being careful with lotions, powders, ointments, all of that. I know they can get irritated and I'm just pointing right here so you can see me. Like if they're having radiation to their chest area, you may see the skin becoming real red, excoriated and things like that. We want to be real careful and we want to make sure that we talk to the radiation department to let us know what we need to treat that with. Many times I've used Aquaphor. Have y'all heard of Aquaphor?
Yes, like Vaseline, but
kind of like a Vaseline petroleum jelly type thing. To me, it's like a miracle drug. I was introduced to it with my first child and we use it for like everything now, but it's very, it's not as harsh as some lotions and ointments and stuff. So they may recommend that, but you always want to check with them before you start putting anything on that area because that radiation can come in and have a reaction and they could have a lot worse burns or excoriations if you do that. Wearing those loose soft clothing, avoiding being out in the sun or heat exposure to that area. You're not putting heat pads or anything like that on there because it can also excoriate and help continue that burn going on. What is internal radiation?
That is like if they have, that's like what my dad had, benign prostate cancer, and then they inject seeds into the prostate, and then they, over their half-life, they disintegrate and eradicate the tumor that way.
Right. So again, it's internal. It's somewhere in the body. Many times you see it with the prostate seeds. So they put those seeds within the prostate, so it's targeting that one area. They do it sometimes in the bladder, sometimes the ovaries. But it's radiation that's internal and it lasts a while. So they're walking around radiated. So you want to make sure that you keep distance from other people. You got to be real careful in the house not to expose other people. And sometimes they may even recommend like family members or something wearing a dosimeter film badge to monitor the exposure of radiation.
My
So
dad
we have to be real careful.
in one area of the house, and then my mom and like the pets and everyone else stayed in the other side because and it was weeks that they did that, if I remember correctly, but it worked though.
Yeah, well, that's good.
Yeah, it was great.
All right, so now we're going to get into some of the specifics. Main things to know with skin cancer is that melanoma, it's usually some type of mole or skin lesion or something that turns cancerous. Big thing to know is that ABCDE assessment. I know y'all probably heard of this before, but you're looking at, is it symmetrical? Is the border regular? Looking at the color, making sure it's not changing colors or anything. Looking at the diameter, pretty much you worry about something that's greater than the size of a pencil eraser. And you're looking at any changes. So if you've had a lot of changes with a mole or something on your skin, that might be a clue to go get it checked out. We talked about treatments. Typically, excision is the treatment unless it has spread to other parts of the body. So if it has metastasized, they may do chemo or radiation to get the other part of the body where it's metastasized to. Breast cancer, again, a lot of, some of the same risk factors that you're going to see from different cancers to different cancers. So really pick out the main ones for each specific cancer. A lot of times genetics plays in with breast cancer, the early menarche, late menopause, those long-term use of contraceptives. Think about hormones, right? What are some signs and symptoms? What's going to get people into the doctor?
Lump on the breast.
Yeah, pain or abnormal look or a lump or any discharge or anything just not right. And there's our treatments. Depending on the stage, depending on where it's located, they can do chemo, they can do radiation, they can do surgery. So with surgeries, a lot of times they're removing a lot of those lymph nodes and everything. So what do you see with those patients in the hospital setting? What do we worry about if they've had a mastectomy or lymph nodes removed from an area? Y'all know?
Hormone loss?
We worry about the lymph drainage system. So it's not there anymore. So what can happen if we do sticks or blood pressures, we can get that edema down that arm, right? So we got to be careful. You may see that they have a no sticks or blood pressures in one arm or another because they have a history of a mastectomy. Do y'all know what that's called when they get that swelling in their arms from no lymph nodes? Lymphedema.
Yes.
So you may see people walking around with those lymphedema sleeves. Is to help keep that fluid going back up to the arm. It's kind of like your TED hose to help decrease that swelling. All right, we talked about any of that. Prostate cancer, what's your big risk factors for prostate cancer?
Male.
Male. typically older in age, right?
Alcohol smoking.
All that same stuff, right? So focus on your prostate cancer. Think about what your patient looks like. It's usually those little old men in the hospital. You think kind of BPH symptoms, where that prostate's enlarged, and so they feel that urgency to pee all the time. And then when they get up to the bathroom, only a little bit comes out, right? So they gotta go. And then those are always the ones that really can't get around too much. So you help them. It takes 2 hours to get to the bathroom. They finally get to the bathroom and they pee like 2 drops and then they're done. And you're like, all that for this? And another hour getting them back into the bed and comfortable, and you walk out the room and what happens?
They gotta pee again.
They gotta pee again. So you gotta go through that all over again. Those are the ones you hand the urinal to, right? And then they say, I can't pee sitting down. I have to get up. So think about that. That's part of your signs and symptoms, that urinary retention, that hesitancy, frequency. Of course, they're going to get a lot more bladder infections, and they might start having some blood in their urine. Again, same type of treatments. They may have to do a prostatectomy with that. And looking at your labs, they're looking at that PSA to determine if that prostate has those levels of hormone in there. Just because the PSA is elevated does not definitely mean they have prostate cancer. What else can it mean? If they have an increased PSA level, what else can that mean? Could mean that their prostate's just inflamed, right? Just enlarged. So they do that PSA level to kind of focus and see if they need to look at that prostate. Very important to make sure you draw that PSA level. Do y'all know what a DRE is?
No.
Digital rectal exam. So that's when, the doctor says bend over and cough, right? So they're looking at that prostate, they're feeling it, making sure it's not swollen or anything. When they do that digital rectal exam, it can stimulate things and cause a false elevated PSA level. So you want to make sure you get that blood drawn before you do the rectal exam. What age are we screening for prostate cancer?
Doesn't it start at 40?
50.
I think it used to be 50, but I think now it's 40. So 40 and above.
My husband had his at the age of 40.
Okay, and so then they're going to start doing these screenings to see if you're at risk for prostate cancer. When do we start our screening for breast cancer?
40.
Do 40, and what are we doing?
Mammograms.
Mammograms. What are we doing before the age of 40?
Health check.
Self breast exams.
Self breast exams. Yep. What about colon cancer? What's our screening for that?
Colonoscopy.
And what age do we do that?
40.
At 40. Well, I mean, we get everything checked out. Colon cancer screening is actually 50, unless they've changed it.
My husband had all that because he had like 17 polyps removed.
You just get it at age 40.
They did change it to 40. They're changing everything to 40.
Yes.
I'm surprised colon cancer isn't younger than that, because we were seeing a lot more younger 20-somethings getting colon cancer. Why do y'all think that is?
Because the food and diet.
I mean, everything's convenient now, right?
Yes,
that high-fat diet, this swing by McDonald's or Chick-fil-A, and it's convenient and it's cheaper than eating healthy, isn't it?
Correct, a lot.
And the inactivity, they're not getting out. They want to play the video games more often. And if you're 20 something, I'm not calling you out on that. I'm not in general stereotyping, but
We
not
didn't
me.
have all that when we was younger. We didn't have all those video games. We went outside and rode bikes.
till the street lights came on.
You better be home when those lights came on.
Mm-hmm. All right, so thinking about risk factors for colon cancer, your diet is a big one. Again, with genetics, smoking, obesity, inactivity, alcohol, all of that. And it says older age, but again, we were seeing a lot more younger ones coming in just simply because of lifestyle, right? Your signs and symptoms there, just thinking about your colon, what's coming out of it, right? So bleeding or changes in those bowels. How many of y'all look at your stool whenever you go to the bathroom?
Not gonna lie, I do.
Every time. My daughter does it too, and sometimes she'll even call me in there to look at them. Treatment, same. They may have to get a colon resection or an ostomy to cut out bad parts of the colon, chemo, radiation. They do have that new thing now for colon that screens you to see how prevalent you are for colon cancer. Did y'all see that on TV? Is it Cologuard?
Guy with the box.
Yeah.
Yeah,
So
that's such a smart idea, isn't it?
yeah, you basically send in a stool sample and they'll tell you your pretty much your risk for getting colon cancer. But labs to focus on. So let's see, starting age 50, I guess I need to change that to 40 now, Donna. What's the difference between the sigmoidoscopy and the colonoscopy?
The colonoscopy is your entire colon, and the sigmoidoscopy is just a portion.
Yeah. So they may start that a little bit earlier with the sigmoidoscopy, but your colonoscopy is really going to tell you more about your colon, right? Lung cancer. What's our screening for lung cancer?
A CAT scan or
They don't really have a set guideline for screening, but if you're at higher risk, they would recommend you getting a CT scan.
There's a lung cancer screening CT, and it's cheap. Like that, your insurance don't have to pay for it or nothing. It's only like $100.
You know, I've heard that, and somebody was telling me they were doing that at, I want to say, I can't remember. I want to say LMC, but I don't know.
It's the one in Irma.
Yeah. Okay. Well, that's not a bad idea, especially, you know, if you have a lot of these risk factors, right? What's the big one with lung cancer? Stop smoking. And you think about lung cancer, anything you breathe in, right? So, you know, your factory workers, back when we had asbestos, breathing all that stuff in puts you at a higher risk for lung cancer. What do you think is going to get these patients into the doctor?
their cough.
Really? You think their cough is going to get them into the doctor?
Not being able to breathe efficiently.
Not being able to breathe. Maybe coughing up blood.
Feed them.
But I mean, how many, I don't think smoking is as prevalent as it used to be, but how many people know somebody who smokes and they just cough all the time, right? It doesn't bother them, it bothers us. But if they start coughing up blood, they're probably going to be like, oh, something's wrong. They may have some pain in their chest, some shortness of breath. Those kind of things are going to get them in. I had a patient one time on my oncology floor. He was a construction worker, and what brought him into the emergency room was he went to pick up a cinder block and his arm snapped. So he broke his arm. He came into the emergency room of course, they're, looking at his arm and everything, and they happen to notice a mass in his chest. So he had stage 4 lung cancer that had metastasized to his bones. So his bones were real brittle, and that's why just picking up something like that just kind of snapped it. But think of like construction workers, all that dust and stuff they're breathing in. Many of them that I've seen are smokers. If not cigarettes, usually maybe something else. Just being out in that weather, he had that dark, leathery skin from being out in the sun all that time. You just think about, different professions and different things that increase your risk for different types of cancer. Treatments, again, chemo, radiation, they may have part of their lung taken out. They may not have the whole lung taken out. How are we going to positively diagnose lung cancer? Biopsy. So they may have an x-ray, a CT to show us there's something in the lungs, but we're going to do that bronchoscopy and get a sample of that and biopsy it, right? All right, any question on the cancers? Focus on what's on these slides for the specific cancers, no cancer in general. We'll talk a little bit about neutropenia. So white blood cells, really less than 1,000, but 1,500, you're really going to start thinking about it, right? We talked about what it is. Usually their first sign of infection is going to be an increase in their temperature. That's usually, we're going to have them call us and we're going to try and figure out where this infection is coming from. We're going to do blood cultures. We're going to check their urine. We're going to check their chest x-ray. What are we looking for in all three of those things? What types of infections are we looking for?
Pneumonia.
All right, so chest x-ray, we're going to see what those lungs are looking like. Think about your patients going through treatment. They're fatigued. They're not getting up, moving around as much. And what do we know about our hospitalized patients laying in the beds all the time?
Easy to develop pneumonia.
They get that atelectasis and it starts catching all that bacteria. They can end up with pneumonia or different blood cultures. It can get into the blood. They're looking at the blood cultures to look for any bacteria in the blood, and UTIs are a big infection, right?
Yeah, respiratory infections and UTIs.
What was that, Jody?
Respiratory infections and UTIs.
Mm-hmm. So they're going to do all these cultures and chest x-rays to really specify, see if they can figure out where this infection's coming from so we can target the treatment and knock it out, because their body can't fight it off, right? We're going to start with a broad spectrum antibiotic. And what do we need to do before we start any antibiotics?
Culture.
Obtain those cultures. What's going to happen if we start the antibiotic and then get cultures?
It's going to mask, or it could mask, which infection they really have, and you're just treating a broad spectrum, which leads to antibiotic resistance.
Yeah. So if you start the antibiotics before you get the cultures, these antibiotics are going to go ahead and start working. It's not going to wait on you and say, oh, okay, got the cultures, now I'm gonna start working. So it may kill off some bacteria that's there that you may not get in your results. Know this slide. These are our neutropenic precautions. What kind of room do we want these patients in? A room with a partner?
No, an isolated room, and definitely clean precautions.
the negative pressure room too, right? Where the air's being blown outside.
No, they don't need negative pressure, and they're not even on any type of other precautions such as droplet contact, anything like that. They're strictly neutropenic precautions. You just want to be mindful that you're not letting visitors come in that are sick, or making sure that everyone coming in and out are washing their hands well. We don't need to glove up and gown up. But if they're going to a procedure, what do we need to do to them?
Put them in a
Mask them.
mask.
We want to make sure that they have a mask, because they're rolling out in this whole, I think, a whole big crowd of everybody coughing all over them, right? No fresh fruits, veggies, or flowers in the room. Y'all know why that is?
Pollen.
So pollen, bacteria grows on those veggies, flowers, different things. Flowers, you have that water in the bottom that can get stagnant and just be a cesspool for bacteria, right? So we want to keep their room clean of that. In the hospitals, they will not send them up fruits or veggies. But at home, you can educate them to, if they wash their fruits and vegetables really well, a lot of times if they have a skin on them, if they can take the skin off, and with your vegetables, if they cook them really well, then they can have them. But in the hospitals, they don't send them anything.
When would you do reverse isolation?
This is pretty much reverse isolation. So you're protecting the patient from everything else. Does that make sense?
Yeah, so you don't have to wear any PPE or anything.
Correct. So what would you do if you came in that morning and you have a neutropenic patient and you feel like you're coming down with a cold?
Get somebody else to take care of them.
You probably want to go to your charge nurse and say, hey, I might not be the best one. Let me switch patients with somebody, because you don't want to go in there and get this person sick. And in my 8 years of taking care of oncology patients, they are real particular. You know, I know at LMC, all our sanitizers are on the outside of the room. So you're sanitizing before you go in. Well, they don't see that. And so you walk in, they may say, oh, can you please wash your hands? You know, don't get into a back and forth, well, I did it outside. Let them see you wash your hands, make them feel good. I've learned so many tips and tricks from my oncology patients on traveling. You know, your remote controls are the nastiest things, right? I had so many oncology patients that would take saran wrap with them and wrap their remotes and things like that, so that they wouldn't be exposed to anything. We don't really use their phones anymore, but making sure we clean our phones. I mean, we're touching our phones. How many of y'all clean your phones regularly?
I know I do, because of COVID.
Mm-hmm.
Strong immune system.
You said you have a strong immune system, Courtney?
Yes, ma'am.
You know, sometimes you wonder if we're doing our kids a service by making them sanitize and wash their hands so much, because, you know, then they'll never get exposed to this stuff, and then they're sick all the time. You let them get a little dirty, right? That's what we did. We played in the dirt.
Just let them eat those Cheerios off the floor.
5-second rule. But the 5-second rule does not apply in the hospital. I don't care who you are.
Nope. I know that much.
No.
It's COVID.
Oh, especially now. It's COVID. I remember when I was working nights and I went down to, I was at LMC, I went down to the cafeteria, and it must have been her grandma, and she had this little kid there. It was, you know, middle of the night, but they must have been there with her parents or something, and they came down to get something to eat. The little girl had her tongue licking all down that tray, that tray support in front of the food. And I was like, oh my God, these kids.
My kid once pulled off of gum from underneath the table and started chewing it. It's so gross.
Gross. My daughter wants to check out every porta potty. And I'm like, you don't go in porta potties unless you really have to go. And in any bathroom, they want to touch all over everything. It's like, ugh, building up that immune system, right, Courtney?
Exactly.
All right. Any questions on neutropenic precautions? Any of the cancer stuff? All right. Real quick on herpes zoster. What is herpes zoster? What's another word for that?
Shingles,
Shingles. How do we get shingles?
chickenpox.
It's where you've had chicken pox when you were younger and it goes dormant and it's a reactivation of that chicken pox virus. So it usually occurs later in life. Usually stress can bring it out, poor nutrition, a compromised immune system. Has anyone in here had shingles or know somebody who has?
I had when I was pregnant with my son.
Oh, you were pregnant.
Yeah, the doctors, they didn't realize I had him until I had delivered. And I guess they ran some type of blood work and they showed where I was exposed. So they immediately had to put my son in the NICU because they weren't sure if somehow he got it or anything, but he didn't. He was fine, but they all missed the shingles. I had it like right underneath my armpit.
Mm-hmm.
And it was a little bit of itchy, but it wasn't like a bad case.
That's good. That's good.
Yeah.
They can get very painful. And it actually kind of looks like chicken pox again. And it's usually along one little dermatome that your nerve system here. And a lot of people, if you have a bad case, they talk about how painful it is. So you definitely want to medicate them with some type of pain meds. They usually put them on an antiviral to kind of help increase the healing process of it. But sometimes it can last a pretty good long time. Anybody else have experience?
We had an outbreak at our nursing home years
Oh
ago.
my gosh.
It was an outbreak. It was awful.
They do have a shingle shot though.
Mm-hmm.
So you're going to get the vaccine, usually 60 and older, because usually it's older population. But you guys are at risk because of all the stress that you're going through in nursing school, right?
Mm-hmm.
If you've had the chicken pox, any of y'all not had the chicken pox?
Yes, I've had them.
I have too.
My
They
mom
made us-
allowed me to touch my brother and be around him when he had it.
We all got put in the room together to get it. Once one person got it when we were smaller.
Oh, that was miserable. You had to put that pink stuff all over it. What was that?
Calamine lotion.
Calamine. Those younger ones that have had the vaccine, y'all missing out on the chickenpox experience. All right. Any questions on cancer, herpes before we get into hepatitis? All right. So just a little background here on the liver. Know your different liver functions. So if your patient has hepatitis or some kind of liver disorder, you can kind of know what kind of signs and symptoms that you're going to see, right? So if we know that it produces substances that regulate blood clotting, what are they at risk for sometimes? They're not able to clot, so they're at risk for bleeding, right? Mm-hmm. It helps in absorbing all these vitamins. So what does that tell us?
They'll have nutritional deficits.
Yeah.
All right. So we may have to supplement some vitamins, right? It helps our body fight infection by removing bacteria from the blood. So if it's not able to do that,
risk for infection.
Yeah. We may have more infections. It breaks down nutrients from food to produce energy. So what are we going to be? Fatigue, right? It removes all those toxic byproducts of different medications. So it helps metabolize medication. So what is that going to do?
Toxicity in the body.
So if it's not able to break down those toxins, then you may start having elevated levels of medications in your body. Prevents shortages of nutrients by storing vitamins, minerals, and sugar. So it's not gonna do that for us, right? So what might we see?
Imbalances like electrolyte imbalance is one. I don't know, blood sugar problems maybe.
Yep, blood sugar issues, yeah. Just, some fun fact, 200 to 400 mils of blood is stored in your liver. Did y'all know that? All right, some labs. Again, don't get caught up on the specifics of the numbers, just know your ranges. So if you have a bilirubin of 2.0, what do you think you're going to see? Jaundice, right? That's what's going to cause the yellowish appearance. You see it maybe more in the whites of the eyes a little bit sooner than anything else. Know your AST, ALT, albumin's going to tell you your nutrition. Ammonia, what happens if our ammonia is elevated? Y'all know what your patient's going to do?
Do they get a UTI?
No, they get real confused. And the way we bring it down is we give them lactulose. Y'all know what lactulose is?
A laxative.
It's a laxative. So they're going to give them pretty regularly, taking that lactulose, which is going to cause what?
Diarrhea.
Diarrhea. And so that lactulose is going to hold on to that ammonia and get rid of it, that diarrhea. So that's going to help bring that ammonia level down. Again, with these derm biopsies, how are we going to diagnose any liver disorders? The liver biopsy.
Yeah.
Yeah. Your x-rays, CTs, MRIs, all of that is gonna picture the liver for you. You may notice ascites, enlarged livers. You might see the enlarged spleen. Your EGD is going to be if they have esophageal varices, which is those bleeding little vessels around your esophagus, which is just caused from buildup pressure from that liver not doing its thing, and it kind of causes those little veins around the esophagus to kind of burst, and they notice some bleeding. Encephalopathy, you're going to notice, of course, with that high ammonia level. So when a patient has jaundice, other than the yellowing of the skin, what other symptoms are they going to have?
Yellowing of the skin, yellowing of the eyes too, right?
Mm-hmm. It's going to cause them to be very itchy. So many times we have to prescribe some antihistamine so that they're not tearing themselves up. They will scratch so much, you'll see that they're starting to break down the skin. You'll definitely see claw marks up and down the arms, the back, the belly, the legs, all of that. So for hepatitis, we do these antivirals listed there. Interferon, I see a lot, and the ribavirin. I'm going to give them some vitamin supplements like we talked about. If they have ascites, how are we going to get rid of that fluid in the belly?
Diuretics.
Diuretics. Encephalopathy, we're going to give that lactulose. Think about, I know most of us have already been through SimLab. Think about lovely Miss Blakely. Y'all remember her?
Mhm.
Was she pregnant?
No.
No.
No. What was wrong with her?
She had a hip fracture, right?
She was
Yeah, but why was
liver
her?
failure.
She had a situs in her.
She had ascites in her belly, right? I know those of you who had her will never forget her, right? Kind of bad. So she had that ascites. So you're going to see that big swollen belly like that, and sometimes they will actually put a needle in the stomach and drain off that fluid if it's causing a lot of side effects for the patient, like if they can't breathe or they're not comfortable or causing a lot of pain with pressure putting on there. All right, we talked about jaundice, we talked about ascites, varices, encephalopathy, those nutritional deficiencies. Let's see, let me find this lovely slide for you guys. We talked about what the patient's going to look like. If they have jaundice, their urine's going to be dark. They may have some nausea, vomiting, decreased energy. We talked about that. Their stools may be a little bit clay colored. A lot of times they have pain around that area. I'm just going to all right, this slide right here is going to help you with all these different A, B, C, D, E hepatitis. So I would focus on this slide if you know which ones have vaccines, the basic treatment for them, know which ones need antivirals, that kind of thing. You should be okay on the test. So I print out that slide and just keep it with me. How are we going to treat them? Again, rest, diet, increase their fluids, medications treating your symptoms, and any vaccines that they may need. So let's talk about diet. What kind of diet are these patients going to be on?
Low residue diet.
No, they're going to be a high carb.
Yeah.
To help keep that blood sugar up, and you're going to try to just get as much calories in them as you can, and you're going to lower that protein and fat a little bit because those are processed through your liver, so we don't want to overwork the liver. We're going to kind of give the liver a break. Increasing those fluids. How many of y'all drink a gallon of water a day? How many in here?
Absolutely not.
I try, but man, it's hard, isn't it? Have y'all tried?
Try.
I have half a gallon jug, so I try to like at least drink one.
At least drink. Do you get through the one?
I thought about it.
Yeah. If I get a new cup, I might try, but after that,
What'd you say, Courtney?
I get a new cup, like a new service, I might try, but after that, nope.
I try, and so think about trying to get these patients to increase their water intake, their fluid intake, right? It's hard. I mean, even if it's not even water, if it's just anything, I just don't drink a lot of fluids in a day, period. These are going to be ones that you're going to encourage those small, frequent meals. Why is that?
The lack of appetite, right?
Lack of appetite. They don't have an appetite. They're maybe a little bit nauseated. So, when your patients are like that, you're not going to want to sit down to a big old meal and try and finish it, right? Let's do a little bit here, a little bit there, and try and get all these calories in over the day. Again, moderate protein, but if their ammonia level is increased, you're going to decrease that protein level. So then you're going to go to a low protein diet so that you don't have to fight with this increased ammonia trying to get out the body. High carbs, moderate fat, Don't go out to McDonald's every day, right? Not time to eat Mexican. Your different vitamin supplements, and then preventing that anemia. So what are we going to teach them? Go home, finish drinking your liquor, right?
No, avoid alcohol.
No alcohol.
Take naps or rest.
Rest. You know, kind of group your activities to where when you have a little bit more energy, you get more out of the way. Avoiding over-the-counter meds. Many of those are hard or processed through the liver, and so they're hard on the liver. So you don't want to take any of those, especially your Tylenols, your NSAIDs. Those are going to increase work on your liver when we're trying to let it rest and heal itself, right? How are we going to prevent it? Don't drink the water, right? Y'all hear that when y'all go in different countries and stuff?
Mm-hmm.
I think they're probably a little bit better now, but why did they used to tell you don't drink the water?
Because of the bacteria and it's not filtered.
Right. They had different purification systems than we do. Some of them don't even have anything. And so they're all their water is just coming from the same place and being mixed and matched. And so when you drink that, you're going to get that, what they call traveler's diarrhea, right? Because you got that bacteria in there. Don't share your needles, right? You don't know what Joe Blow has beside you. Y'all don't use needles anyway, right? With the hepatitis, don't focus on your incubation days. Just know that it can take a long time for it to actually show your signs and symptoms. But in the meantime, it's doing its work on the inside before you show it on the outside. And many times you have those mild flu-like symptoms, low-grade fever, you're tired, you just don't feel good. So again, you chalk it up to something else. Stressed in school, work. I've been working a lot more often. There's been so much going on. That's why I'm so tired. The weather changed, right? Pollen's out, all these things. And then they're going to go even longer without being diagnosed. Usually you're starting to notice that jaundice or that dark urine. Makes you think about your urine, don't it? And they're going to notice those things, which is going to get them in, and then they're going to have tests for the antibodies and know that they have hepatitis A or B or whatnot. Preventing, same old stuff, right? Hand washing, that pops up everywhere. Again, don't get focused on the incubation periods. Know how it's transmitted. So if you know how it's transmitted, you know how to prevent it, right?
Mm-hmm.
Make it easy.
Are they only transmitted by like blood and sharing needles and that kind of way?
Fecal matter.
Oh, I see right there.
Yeah. So if you come up here, A and E, if it's a vowel, it comes from vowel.
Oh, that's smart. Okay, yeah, I see that. Okay.
Yeah, see, that's why I like this slide.
Somebody got creative with that one. That's great.
Yeah. Hepatitis B is going to be your bodily fluids. C. And then your D is actually just going to come from your hepatitis B. It's going to develop if you have hepatitis B. So know that slide, right?
Mm-hmm.
Again, hepatitis B treatment, they do have antiviral agents for that, along with, you know, your bed rest, nutritional support, all that. We all have received our Hep B vaccines, right?
Mm-hmm.
Has anybody had hepatitis A vaccine?
Mm-mm.
I did. I got exposed to it at Wild Wings on Harbison.
Oh, every time I do this lecture, somebody tells me
The one day I have a salad instead of fried wings, but it was apparently like one of the waitresses, and so she wasn't running food, hopefully. And we were sitting at the bar, but she apparently had shared a dirty needle, I found out from the manager.
They told you all that?
Well, my friend used to work there, so I was like, you need to find out why I'm having to go get a hepatitis A, because they put it on the news, and that's how I saw it. And I looked up the dates. I was like, oh my gosh, I cannot believe I was there.
Goodness gracious. Anybody else got any stories? So how many of you wash your watermelons before you cut them?
We do.
I used to not until I
Yeah,
had
we
a
just thought
student.
about
When
it.
I was little, we didn't, but because my husband a big old OCD.
I wash all my other fruit. I never thought about washing watermelons, but think about them being in the fields, animals coming and doing their business on them, and people touching all, one after the other, and they're never getting clean. So when you cut through that watermelon, whatever's on the outside is going to the inside, isn't it?
Mm-hmm.
What do you wash it with?
Just like you wash your fruits and veggies.
Yeah,
I
water.
just rinse mine off. Like,
Yeah.
I don't know what to put on them.
Yeah, you don't have to put it. You just rinse them
Wash
off.
them, yeah.
Hey,
So-
Miss Coles, is it safe to eat the skin off the apples? I feel like too many people touch them.
Well, that's why we wash them first, right? I've noticed too lately that I feel like a waxy coating on them. I don't know what that is, but I make sure I rinse mine really good. My strawberries, my grapes. You remember we used to walk in a grocery store and eat them grapes right out the bag, didn't we?
Yes, yes.
Today, you know we did.
Yes, yes, and yes.
I still do that sometimes.
I need the whole bag walking through the grocery store.
Y'all talking about used to, look, still.
Oh my
Make
goodness.
sure them things are good before you
You
buy
know
them.
that's stealing, right?
Yes.
I still pay for it.
Yeah, but it doesn't weigh as much, does it, Mariah?
I got some grapes at Sam's
You're
in the
right.
summer that were called cotton candy grapes.
Cotton candy grapes.
They taste exactly like cotton candy. I didn't even wash, just pop it right in my mouth. That's so gross.
Well, I think about back in the day, when I would go to the grocery store with my mom, they had this big old candy thing that it just was like, little pieces of, wrapped candy that you pay for. But as a kid, you don't know that. You just run it up there and you grabbing all this candy. Y'all remember that?
Mm-hmm.
Today? Yeah, I know you do.
I like at the bakery, the sample cookies, the free sample cookies.
Oh, yes. They didn't do that when we were growing up.
Oh, yes.
They do it
That's
now.
because we
though.
got our own samples at the candy bins.
We got our own kit. Yep.
Right.
All right. So with hepatitis C, again, know how it's transmitted and you can know how to prevent it. It does they do have a new treatment now. That's my next slide. They do have a new treatment. I don't know if y'all heard commercials. I refer to my commercials all the time. But not as much anymore. But last year, the last couple of years, they were saying, if you're a baby boomer, go get tested for hepatitis C because there's a new treatment now. Why would they target the baby boomers?
Was it they didn't have that back then?
Look at how they're transmitted.
Yeah.
Baby boomers, I think of Woodstock, but I don't know why that comes to my head. But
Smoking and drinking and drugging and all that good stuff.
And no condoms, no nothing. And
Yeah.
so somebody had it, they're just spreading it everywhere, right?
Mm-hmm.
So they were encouraging them to go get tested for hepatitis C so they could get a treatment for them. And actually they're showing now that they're no signs of hepatitis C after their treatment, they're even able to donate blood now, which was an eye opener to me because I feel some kind of way about knowing somebody used to have hepatitis C and now I get their blood, right? It's kind of weird.
I wonder what that later on, if you do get a blood transfusion, would that make you at risk to get that hepatitis
I don't know.
later?
I don't know because it's still fairly new. All right, and hepatitis D, we don't really focus on that a lot. Just know if you've had hepatitis B, you're at risk for D. See, it's getting kind of close to the end of lecture now, right? And hepatitis E, we don't really, I just know that it's also fecal oral route like Hep A.
Is one of I'm sorry, are one of the like A, B, C, or D, is one worse than the other?
Hepatitis C, they say that many of those end up with liver failure to where they end up having to have a liver transplant. So I think hepatitis C would be the worst. And this is also too before they even had any treatment for it. So there was no treatment. So hepatitis C would have been the worst to have because there was no treatment for it.
And then the most common one that you'd see would be A and E?
I would say A.
A?
Yeah. B, not so much because of the vaccine for it. Not many people are getting hepatitis A vaccines just because, you know, they don't really promote it that much.
You know, my guy had B and C.
Yeah, he did, didn't he?
Yeah.
He had both.
So they can have more than one at a time.
Yeah.
Dang.
All right, and so what is non-viral? Those are all our viruses. What is non-viral?
It's not infection. It's not infection produces like from medications.
Correct. So it's going to be caused by chemicals or drugs or something that causes those changes in the liver. Can cause necrosis in that liver tissue, which can cause, you know, inflammation and all of that. Typically, the treatment for that is to remove whatever caused it. So we've seen patients in the hospital that have gotten overdosed with different antibiotics or other treatments. I know a lot of the HIV treatments are very hard on the liver. And so if they get a buildup of those, it can cause the non-viral hepatitis. And so they end up having to stop treatment and may have to switch treatment regimens because of that. Again, these are just a list of some of the medications that are more toxic to the liver. So if you do have any liver disorders or anything, elevated LFTs, then you want to be real careful with these medications. I don't expect you to memorize any of these. I'm not going to test you on any of these, but just know that, you know, if you're out there taking care of patients and you're, you know, doing your med cards and stuff, always look at that. If they have any liver stuff going on, look and see what the toxicity is for that liver, because you may notice them decrease in doses or using something else other than these to do any treatments or anything. Now we already talked about that. Now we're going to kind of switch gears a little bit and talk about infectious diseases real quick. What are the different types, 4 different types of precautions that we can practice? What are those?
Standard precautions.
Standard precautions. That's one we use for everybody, right?
Sterile precautions.
Droplet precautions.
Airborne precautions.
Airborne precautions and
contact.
So when would we use airborne precautions?
Like tuberculosis and diseases transmitted through the air.
through the air. So TB was the big one that we used to worry about. Now we've got COVID in the mix of that, right? And what kind of special things do we do for airborne precautions?
Negative pressure
Negative pressure
room.
rooms.
Wear masks.
What kind of mask?
N95.
N95. So you have to be fit tested. That mask has to fit you to where no air can get in there because you don't want what they have, right?
And you have to wear, you put them in that 6 to 12, changes the room where the air goes back out instead of come back in.
That's a negative.
Negative
that's a
pressure
negative
room,
pressure. Yeah. What about droplet? Who's our droplet precautions?
Is that for?
I can't think of anything specific other than like, I don't know, the flu.
The flu. That's our big one is the flu. Just because of the coughing, and those droplets is what spreads the flu virus. So what kind of precautions are we doing for them for droplet? What kind of things are we doing?
Aren't you supposed to stay like 3 feet away?
3 feet away.
Obviously don't touch their environment, their personal environment.
So we're going to gown and glove, right?
And they will wear a mask if they come out, right?
They will wear a mask, and the airborne wear a mask if they come in. But we also wear a mask with droplet because we don't want, but it doesn't have to be a N95 mask, just a regular mask. So we don't want them droplets getting in our mouth and our nose, right?
No.
What about contact precautions?
Skin diseases like C. diff or it's another one. What is that flesh-eating disease?
MRSA, VRE.
MRSA and VRE. You're getting too much
It's
there.
something else though. It is another
What is VRE?
VRE is vancomycin resistant erythromycin or something like that. It's vancomycin resistant. So vancomycin is one of our broad spectrum antibiotics. So if they're resistant to that, that means that it's not going to help treat whatever they got, right? So,
right, and then you have to wash your hands with soap and water for C. diff because the whatever it is, the other stuff won't work. Like the hand sanitizer stuff won't work.
Right. Yeah. Yep, C. diff, we're not doing hand sanitizer, and a lot of times they will even put like tape or something so people don't falsely use the sanitizer. We're doing the good old soap and water, right?
Correct.
And you leave your, I had a patient just a couple weeks ago that had C. diff, and you had to leave, they have a disposable stethoscope that you left in the room. You don't use anything of your own that's going to come out of the room.
Right. And if you do, you need to make sure that you clean it really well. So many times you've noticed that those of you that work in the hospital setting, if you have one room with C. diff, what do you usually have beside them?
The same patient. It'll be another patient with the same thing.
Yep. It's usually kind of 3 in a row or 2 in a row, because what do y'all think has happened?
It's spread. We're going from a good person, not a person that doesn't have it. Yeah.
And you didn't clean some type of equipment and somehow you spread it. It's very interesting that way. So you got to make sure you're doing your hand hygiene. If you're cleaning your equipment or you're leaving, the equipment in there to be used only on that patient so that you're not bringing it out, exposing other people.
They used to leave the Cavitsit wipes in the rooms, but now they don't. They got so cheap and stingy at the hospitals.
Well, I think a lot of those supplies with COVID, I think just like with our Lysols and Clorox wipes and stuff, for some reason, they all just kind of started disappearing. So, and hospitals weren't exempt from that. They were, they're low on, struggling for gloves, all your PPEs, a lot of your wipes and stuff like that. So that's why we have to try and be mindful of, making sure that we're only using what we need to be using.
I had to wear like a plastic gown and double glove when I went in there. But you know what? The person that dropped off their meal went in there with nothing.
You'll see that, yeah. But that's on them. And what gets me is all my techs can vouch this for me. If they have C. diff, but they're walking around the hallways, right?
Yes.
All right, so that's pretty much protection in a nutshell. What kind of questions do y'all have?
What about isolation precautions? Did we have to go know that one, or did we go over that one?
Yeah, we talked about contact, droplet, and airborne. Those are your isolation precautions.
My only question is, what's the difference between a surgical mask and an N95?
A surgical mask is basically the mask like we're wearing around now, like when you're in the hospital and stuff. N95 masks, they form more towards your face. And so you actually have to get fit tested for those, where you put it on, you put a size on, and you push it down around your face, and they put this big hood over you, and they spray some spray to see if you can smell it. If you can smell it, that means that air is getting through your mask. So they either need to change mask, or you may not be able to wear an N95 mask. So then you'd have to wear that big hoodie they call a papper.
Yep, and they make men's cut their beards.
And the men, if you have a beard, you can't wear an N95 mask, because that beard is going to allow that air to get in through that mask. Did that clear it up, Destiny?
Yes, thank you.
My internet went out right after I asked that question. So what would be like where you would use isolation precautions, like for what kind of disorder or disease or whatever?
Isolation precautions is your contact, droplet, airborne precautions.
Okay,
So contact, we talked about MRSA, VRE, and C. diff, droplet, flu, and airborne was your TB and your COVID.
Okay, I got it. Thanks.
Any other questions? All right, so real quick, we're going to go over some NCLEX questions and see how y'all do. All right, I'll give y'all a second to read them, and y'all tell me what y'all think the answer is.
That be C?
All right, I hear C. Anybody else?
I think C too.
I agree.
C.
C.
All right, so A is a risk factor, right? So why would y'all pick C over A?
Because we have colorectal cancer and Crohn's. Crohn's increases the risk for, sorry.
Yes, it's an IBD.
Right. So of the two answers, that Crohn's for 20 years would be a little bit more higher of a risk than just smoking, right?
Yeah.
What about the vegetarian diet? Did we say something about diet? That diet effect?
Yeah, but it's not a high risk. It's like low.
Yeah, it's very low. That's a good diet, right? It's not high fat, high protein, all that. The red meats are going to increase your risk, things like that. And what about a family history of lung cancer?
It can be play a factor, but it's not.
Yeah.
Colon cancer.
Right.
I would have picked that as my second option, just because, I mean, my family has had stomach cancer, breast cancer, lung cancer. So it doesn't, when I just think of cancer, I figure,
Just a family history of
yeah, if
cancer.
it runs in the family, you can get anything.
Yeah. All right, next question. Y'all love these questions, don't you?
Hate 'em. I'm gonna say B.
Me too, B.
All right, why would y'all go against A?
Because the peanut butter squares are whole milk is fattening.
Mm-hmm.
Oh, the flour.
Peanut butter squares is sugar.
Yeah,
All right,
the whole milk threw me off on that one.
Why not C?
Because of the cream cheese.
Cream cheese and bagel.
Cream cheese, and usually when you see cauliflower salads, those are usually like what, a mayonnaise based kind of thing.
I don't eat that, so I wouldn't. When we used to go to the health department to get our shots, and they had a picture of, in the old time, they had a picture of a lady with an STD and it looked nothing but
oh my God.
That's so gross.
I was trying to figure out where that story was going.
I would not eat that. That is conditioned in my head. I cannot eat it. Cauliflower was off the list.
Oh my gosh. And why not D?
You got sour cream. You got oatmeal raisin cookies.
Potatoes starchy.
Mm-hmm.
The sandwich, the bread.
All right, so your bran muffin, skim milk is good, and stir-fried broccoli. Usually your stir-fried things are not as fattening as your fried stuff, right?
So what were we looking for? High fiber and what else? Low fat?
What are y'all looking for
I thought it was high fiber, which is why the broccoli and bran muffin would have high fiber. And then I thought it was also low fat, which would be conducive with the skim milk, although I'd probably cut the skim milk out and replace it with something else.
Yeah, milk with broccoli, but you want that high fiber, lower fat. Think about, what we recommend people to eat, healthy foods, basically.
Yeah, and broccoli has good protein as well.
And bran, that's got your fiber in there, right?
Anything brown, right?
Mm-hmm. Well, except for chocolate. All right, question 3.
B.
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 Why not A?
That might
Just
irritate.
full strength, they'll irritate it.
And
That full strength hydrogen peroxide, that's gonna, in every 4 hours, it's gonna really start wearing down those gums and stuff, right?
And would it kill also good bacteria that might be in the mouth?
Yeah, possibly.
And
I just
hydrogen peroxide can cause holes also, right?
can cause what?
Holes.
Yeah, it can start breaking down those gums. I just can't imagine rinsing my mouth with peroxide, but anyway. Why not C?
You said avoid
hot things.
fluids.
Yeah. Hot tea, that has the potential of causing some damage, right?
Yes.
Let it, and if it was warm or room temperature, then that would be a better answer. What about D?
You would limit flossing or use some other tools while you have a stomatitis.
Yeah, you definitely don't want to increase that flossing, right? It's going to start damaging the gums, hitting those gums, making them bleed. All right, question 4.
B.
C.
No, not B, not B, not B, not B. C.
B.
C. C.
I'm hearing B and C. What do y'all think?
C. C. C.
Yeah, did I hear
because
D?
hair-
Because the hair is not going to quickly grow back. It'll
or
be
to its original appearance.
And you want to get ahead of it and go ahead and have their wig fitted so that they don't even really have to hopefully experience like as traumatic an effect if they already have their backup plan in place.
Right. So A, I wash and massage my hair every day. I do wash my hair every day, and it really hasn't stimulated the growth yet. Again, we know it's going to be temporary, but we don't know how quickly it's going to grow back. And
Nope.
many times it doesn't grow back to the same appearance. And then D, we don't want to isolate anybody, right? That's not our ideal situation, especially
And also they get their wig first so that the person can see what their hair looked like before
Right.
they lost their hair.
right. So a lot of times they can match their hairstyle now. They don't have to look any different.
I think I changed mine.
I think I would change mine too. I'd have many different wigs. I want to wear wigs now. Did I skip one? No.
Yeah,
okay.
go ahead. I'm gonna put the platelets, temperature,
And the white blood count?
and the white blood cells. So B, D, and E.
B, D, and E. Hemoglobin, that's within the normal range. BUN, what's our BUN ranges?
10 to 20.
10 to 20, so that's within normal ranges. And then your urine specific gravity is normal. So your platelet counts are low, really low. Your white blood cell count is low. We got that fever going on, right? What we gonna do?
Give them an antipyretic for the fever.
And an antibiotic, preventative antibiotic, maybe.
All right, what we gonna do before we start an antibiotic?
Oh, we got a
Oh,
culture.
we gotta, yeah, run a culture to see what it is.
Blood cultures, urine cultures, and a chest X-ray, right?
Correct.
So they obviously got something going on with that temperature. And then they're all going to be at risk for
Bleeding,
and
infection.
Section. How am I'm sorry. This is going to be a dumb question, but I am asking it. How am I supposed to know how many numbers the white blood count is? That's math. And that I came out with 23. It just makes no sense to me.
Because it should be 5 to 10. 5 to 10. That is 2.3. So that's 2,000. 20.
Okay. I put 2.3 and I was like, that's just 23.
so think about it can either be like if this was 2,300 or looking at the 5,000 to 10,000. But think about 5 to 10. So you're taking off the three
zeros.
The 3 zeros. If that makes
I didn't add any zeros. I was like the number is 23 like 0.0. I was like, I'm so confused. I'm doing this wrong. I didn't think of it as like 2,300 or something.
So just think of it here, white cell 2.3, and then you're thinking 5 to 10 is your normal range. So it would be low. Would we be neutropenic?
No, because that's less than 1,500.
Right. All right.
B.
I was going to say B2, but I was guessing.
Because you have yellow eyes and yellow skin. Yellow skin. B.
So the icteric phase is just your jaundice phase. Your pre-icteric phase is when you're sick and it's before you have that yellowing of the skin. And then the post-icteric phase is after you start healing and that jaundice goes away.
Okay.
So the yellow sclera. Tari schools, what stools, what would that indicate?
Dear. Oh, blood in the stool. I'm
Blood in
thinking
the
about the
stool.
jelly like Tori is blood in the stool.
And shortness of breath, not with the liver, and then that light frothy urine. What is frothy urine going to indicate?
UTI.
Usually that frothiness is going to be the protein in your urine.
Protein.
All right, next.
I want to say A.
I think it's A too.
A.
All the other stuff is funky. A.
Yeah. Okay. So B, we just talked about there is a cure now, right?
Mm-hmm.
C, we don't want to be judgmental. You're kind of judging them and saying that it's expensive and you probably can't pay for it anyway, right?
Mm-hmm.
D is kind of, again, judgy. You're judging them for the lifestyle choices that they've made. And, you know, that's kind of a judgy statement. There are probably better ways that you could come around and say that, right?
Mm-hmm.
Yeah.
But A would be your better choice.
Bleeding. B.
What y'all think?
White blood cells are good. Hematocrit is good.
I agree with bleeding.
All the other ones are low.
Risk of
Yeah, because the
infection.
platelet count is low, so you'll be risk for bleeding.
Yeah, so white blood cells, what's our normal range?
5 to
5
10.
to 10.
5 to 10, so it's in there, right? Hemoglobin, what's our normal range?
12 to 16.
Okay, and then platelets are obviously low. So if you're thinking about this patient, they're getting chemo treatments, right?
Mm-hmm.
So a lot of, okay, they may be at risk for infection, but looking at that white blood cell count right now, they're really not at high risk because they have the white blood cells to fight it off, right?
Mm-hmm.
Imbalanced nutrition. We talked about, you know, chemo treatments and the malnourishment and all that, but nothing in this question really makes you think they have imbalanced nutrition, right?
Correct.
And disturbed body image. They may lose their hair, right? That may relate to them. But if you even take imbalanced nutrition and disturbed body image and risk for bleeding, which would take priority?
Risk for bleeding would take priority.
Mm-hmm. So when you're looking at those three, you say, which could kill me? Well, if you really don't have nutrition and you have bleeding, those can kill you, right? But then when we think about our ABCs, airway, breathing, circulation comes in above nutrition.
Mm-hmm.
Does that make sense?
Mm-hmm.
All right, now this is kind of a tricky one. Let's see if y'all can get it.
It's either A or B. So hemoglobin is low.
A.
Let's say A.
I think it's D.
I say D.
All right, why would you say A? Neutropenic precautions is what?
1,500.
Yeah, you're right. You're right.
That's your white blood cells, right? Less than 1,500. So you can automatically throw that up.
Yeah.
What about B? Remember what I said, that
The
hemoglobin
platelet is low, but the platelets is still within range. So,
platelets are within range, so we have the platelets to clog us up, right? So we don't bleed to death. All right. Yes, we're going to encourage foods with high calories with our chemo treatment, but we have a low hemoglobin. And what did I say about transfusing blood?
But they're going to have a big port for it to go in or a big catheter.
So I said, usually we're transfusing at below 7, right? So it is below 7. And so out of these, I mean, if we're going to transfuse blood, we need a IV catheter, right? I know y'all haven't learned about blood yet, but at least you have to have an IV site. There's no other way to get your blood, right? So the correct answer, you could narrow it down to D. Were y'all able
I would have gotten that wrong.
You would have gotten that wrong.
Yes, because I would have been confused.
I threw this one in on this. There won't be one like this on the test, but just to kind of get your critical thinking flowing. Okay. You got a patient on chemotherapy. You think about all the side effects of chemotherapy. They have breast cancer. These are their labs. Well, then you look at neutropenia. We only put them on neutropenic precautions if their white cells less than 1,500. Well, my white count is normal, so that's out, right? We talked about bleeding precautions, and I talked about how hemoglobin you don't look at that for your risk for bleeding, you look at platelets. So that one can be thrown out. So then we're left between C and D. So we still haven't addressed that hemoglobin, right? And so then that would go with the catheter. Does that help you a little bit?
Yes.
All right, next one, last one. Y'all's favorite, select all that apply.
It's definitely A and B.
B,
A, and E.
E.
A, B, and E. Why not C?
Because you don't want them to take your aspirin. They said.
What is acetaminophen? What's the brand name of acetaminophen?
Ibuprofen. Tylenol.
Tylenol.
It's processed through the liver.
And we all know Tylenol is bad for the liver, right?
Yeah. Liver tox.
Especially if you already have hepatitis. So we wouldn't want to take acetaminophen. And what about wearing a mask?
No, because
it's bloodborne.
Yeah.
I mean,
why would they eat small frequent meals? Because I picked A and B, but then I didn't pick anything else.
Because they're at risk for inadequate nutrition.
Remember, think about these patients, and let me go back up to this slide real quick. Nausea, vomiting, anorexia, that weight loss, they just don't really have an appetite.
Oh, gotcha. I don't know what I was thinking.
All right, so y'all good on that? So Amanda would have missed that one. Today would have missed the last one.
But that would have been a good grade regardless.
All right, I will post this slide because it has all the rationales behind everything, and y'all can look at all these questions. Had some information on neutropenia up there too, the same that's in the slide. So I'm gonna post this slide for y'all so y'all can practice those NCLEX questions. What other questions do y'all have?
It's not as bad when we're doing it together, but as soon as we get to testing, that's when all the nerves and anxiety get the best of us some of the time.
Yes.
Right. I totally understand. I've been in your shoes before. Making sure that you're not cramming the night before, because that's going to stress you out even more. study little bits, little chunks out of time. Don't spend a whole day just focusing on studying. Your mind needs time to rest. So study for a couple hours, retain that, come back and do a little bit more. I know y'all got a test this Friday, right?
Yes.
And we also got other things for you.
Yeah, we're meeting after class.
Yeah. But right now for the class, y'all have a test on Friday. So I know y'all are going to put protection on the back burner for now, but kind of incorporate it in and relate it to other things, especially your labs and everything. Really, if you just think about how we're going to treat things, everything on these slides are very important. The patho is very important, but those are kind of things you keep in the back of your head to where you can make good decisions on your interventions, thinking about your nursing diagnoses, on preventing complications and things like that. So basically, we're supporting the patient, we're preventing complications, and we're treating any symptoms that they may have, right? When you break it down like that, it's simple. When you're looking over this stuff, make it make sense to you. Don't just read over it and try and memorize it. Make it make sense. Your test is on what? Elimination and nutrition? Those kind of go hand in hand. So nutrition is going to be kind of your upper GI, and elimination is going to be that lower GI.
What would you say most people have trouble with in those two concepts?
Dumping syndrome, make sure you understand dumping syndrome. Okay. Y'all always miss the patient presentation of that.
Okay.
So don't only know what it is, what's your patient going to look like and why? So your stomach is this big, right? If I'm sitting up and I eat a meal, how long is it going to be in that stomach?
A long period of time, because it's
not very long, because it's not very big, and it's going to go straight into your colon, right? Straight into your colon there, and then your colon's going to have to do the job of your stomach, which it doesn't like to do. So it's going to shock your system, and it's going to cause cramping. It's going to cause the sweats. It's going to cause that nausea. It's going to try and get it out there, and you're going to have some diarrhea, right? Does that make sense?
What do they do after they eat then?
What do you instruct them to do?
Lie down.
Lie down.
Oh,
with your ulcers, what do they not do?
Eat agitating food, acidic foods.
They don't lie down.
They don't lie down.
Right? Because we want it. That gravity is working. If you're laying down, it's going to have to work a little bit harder to get on through that stomach into the colon. Peptic ulcers, we want it to get through that stomach faster, right? Because we have irritation in the stomach. Gastric, in your gastric ulcers.
And one of them, I can't remember which, and I don't know if is there one that food helps and one that food hurts?
What do y'all remember from that?
I can't remember.
If it's a duodenal ulcer, it helps, I think, like when you eat. Am I saying that right?
Yeah, food helps the duodenal, the gastric, food hurts it. So if you 15 minutes to an hour or so after you eat, you're going to be hurting if it's in your stomach. If it's in your duodenum, then it doesn't start hurting until 2 or 3 hours after you eat.
So make it make sense. Where's your stomach? It's going to go through the stomach first. So if you have an ulcer in your stomach, you're going to notice the symptoms faster. If it's in your duodenum, it's going to take longer to get there, so your symptoms are going to appear a little bit later, right? So, and a lot of times, the food helps it because it's getting your stomach working, and so this right here is not really paying attention. Does that make sense with the food thing?
Yeah, I think so.
Yes, ma'am.
So make it make sense. Really sit, if you really don't understand something, sit down, look at it, look at your structures, look at, sometimes just looking at a picture of where it is in your body is going to help you with that.
Okay, what else did I miss? What about nutrition?
Well, that is nutrition.
Okay, what about elimination?
Elimination, knowing the differences between your
Crohn's and ulcerative colitis.
Don't focus on the similarities. Know that all of them include this. Focus on your differences so you can distinguish between the two.
Which one is worse, Crohn's or UC? I mean, they both seem terrible. Is one worse than the other?
It just really depends on the patient, but I would probably lean more towards Crohn's because Crohn's doesn't attack one part, it's all over the colon.
Right, and there's no cure for that one.
No.
And because it affects all the way through the membrane, whereas the ulcerative colitis, like it's only like the top part.
Right. What else does she talk about with elimination?
Ostomies.
So with your ileostomy,
Bariatric surgery.
with your ileostomies, think about where it is in your colon to determine what kind of stools you're going to have, right? Higher in the colon, you're going to have what?
Liquid.
Or liquid, like.
Down lower, where it comes out your bottom, it's going to be
Or
more
foreign.
right? Makes sense. Bariatric was nutrition.
Hey, Miss Coles, I'm getting a little confused on the nutrition, like with the full liquid diet, then you got the what is it?
Low
The step
residue.
down,
Soft.
the salt, yeah.
I'm not sure what are y'all referring to?
Yeah, like what's the difference in like when they go from full liquid and then they go to clear liquids and then the consistency change again when they get home? Like what type of foods and liquids are available for them?
They're on, remember she said they're on they're on clear liquids. Like each one of those steps, they're in that phase for a long time. It's not like they just go from clear liquids to soft and blah, blah, blah. Like it takes months for them to get all the way through to where they're eating a normal diet. So they're on like clear liquids and then they can add full liquids. And then after that, it's soft.
Yeah, so clear liquids, is that just like
Clear liquids is what it sounds like. Pretty much if you hold it up, you can see through it.
okay, so that wouldn't be like orange juice.
No.
But full liquids, that would be like
Full liquids, so they have more consistency, but if you hold it up, it's so thick. What are some of your full liquids? Is it oatmeal? Grits. And so think about it, it's still kind of liquidy. It's a lot of water, but you can't see through it.
Applesauce.
Yeah, your applesauce. Those
Yeah, I
kinds.
do
So
have a question. My patient was on clear liquids the first day, but they were giving her applesauce because that's how she was taking her meds.
but your patient was a little bit of a different type situation. Remember, we couldn't even figure out why she was on clear liquids.
Yeah, and then they transitioned her, and she was
Yeah.
on full by the time, by the end of the
Yeah.
next day.
Yeah. So hers was a little bit different situation.
And
I didn't know if that was because apple juice is something you can see through, so applesauce was in the same category or something.
So apple juice would be what?
Yeah.
A
Clear
clear
liquid.
liquid. And then your applesauce, think of the consistency of it. It's going to be a little bit more consistency, so it's going to be your full liquid.
So Jello would be full liquid?
Jello's going to be your clear liquids. Think about, because it's not really consistency.
Okay.
I know they have that question on the test and it kind of tricked me the last time.
Just think about how they advance. So you have your NPO, you have your clear liquids, You're going to add a little bit more, so clear to full, and then you're going to go soft, and then you're going to, you know, keep stepping up the way, and then you're going to go up to just a regular diet. But they're never going to be on like a real regular diet, right?
Right, and hopefully their amounts will always be reduced so that they're not stretching out their pouch.
Right. Any other questions? And again, if y'all have questions on nutrition, email Ms. Hainline. If you have questions on elimination, email Ms. Petrarca. Ask them how to make it make sense. Okay.
Was peritonitis the one that had the board-like abdomen?
Peritonitis is your board-like abdomen.
Okay.
That's an emergency, right? That one you're going to call the doctor.
And also, if their heart rate goes up, right? No. Oh shoot.
Usually think about like bleeding, your GI bleeds, stuff like that. Your heart rate's going to go up because it's trying to compensate for that, losing that blood. Your blood pressure is going to go down because those vessels are going to open up to let that blood get in there, right? So your blood pressure is going to go down. So,
right. So it was the heart. If you see an increase in heart rate, that would be your priority, or your thing that would clue you in that that's an emergency.
Right.
Well.
All right. Any other questions?
Ms. Coates, I know we have elimination and nutrition this week, and I was looking at the calendar. Our test for the material we're learning today isn't until the 16th of April.
Right.
Would there be any way that we may have like a review?
I know Ms. Amick will have tutoring. I'm sure she'll have tutoring.
Okay.
But again, this will be recorded, and I'm going to put that up there for y'all.
Okay. And then as far as like your questions, are all of them going to be like multiple choice and select all that apply, or will we have some matching or short answer or
picture? Any of that is up for grabs. Think about the NCLEX. We're trying to prepare y'all for the NCLEX. Mostly multiple choice. You may have some select all that apply. You may have a picture on there, and you may have to do some matching.
All right.
Okay,
thank you. Enjoyed it.
All right. Thank y'all.
Bye.